Welcome to Section 6 of Psychiatry. In this section, we'll be discussing anxiety disorders. This is our psychiatric overview figure, and we'll be focusing on many of the anxiety disorders which you can see in this box. Here is a table showing the anxiety disorders. In each one of these conditions, there's a stress response out of proportion to the stressor. The first disorder we'll discuss is panic disorder, and in panic disorder, a patient has panic attacks. So let's discuss what a panic attack is. A panic attack is characterized by a sudden surge of fear, and it may or may not have a trigger, and the symptoms usually peak at 10 minutes and then slowly subside. And panic attacks present with 4 or more of the following symptoms, including palpitations and chest pain, sweating, shaking, shortness of breath, abdominal pain and nausea, lightheadedness or paresthesias, and derealization or depersonalization, also fear of losing control, and even fear of dying. So there's a lot of symptoms going on here, but if you can think of a panic attack as essentially causing a very dramatic sympathetic response, then everything seems a lot more logical. And it makes sense that there'd be a dramatic sympathetic response because anxiety and stress causes that fight or flight reaction of the sympathetic nervous system. So what effect would a dramatic sympathetic response have on the cardiovascular system? Well, your heart would be pounding, so you'd likely have palpitations and your chest would hurt. And your sympathetic nervous system increases sweating, and you can start shaking as a result of some of that neurological stimulation. And that neurological stimulation can also cause lightheadedness and paresthesias. And what impact would it have on your lungs? Well, you'd be short of breath. And your GI system? Well, you mainly have abdominal pain and a feeling of nausea. And with all of this sympathetic response, your mind is going wild. So you experience that derealization, which is a feeling of unreality, or even depersonalization, which is a feeling of being detached from yourself. So with all of these feelings that are physically painful and distressing, and these thoughts and just feeling detached and unreality, you can have that fear of losing control, and you can even have fear of dying. In fact, a lot of patients who are experiencing a panic attack or talk about the panic attack that they had, they say they felt like they were dying. So coming back to panic disorder, now that we've discussed and defined what a panic attack is, let's dive into the disorder itself. So in order to diagnose a panic disorder, they need to have a panic attack plus one of the following. And more than one of these may be present. For example, they can fear more attacks, they can fear consequences of having attacks, and they can have a behavior change as a result of the attacks. For example, avoiding leaving the house and developing agoraphobia. And to be officially diagnosed with a panic disorder, these symptoms, again, one or more of the following, must persist for greater than a month. So now let's talk about treatment. Treatment is focused around decreasing anxiety. So this can include cognitive behavioral therapy or pharmacological therapy, for example, SSRIs or SNRIs. You can also prescribe benzodiazepines for the purpose of using them as needed if and when they have an attack. Now, benzodiazepines are very effective at calming the patient, and from the patient's point of view, just knowing that they have this medication on hand in case they have an attack can be really helpful in reducing their fear of more attacks because they know they've got an out. So it can help reduce that fear of having another attack or fearing consequences of attacks or normalizing their behavior that may have changed as a result of the panic attack. Now let's talk about generalized anxiety disorder. This is characterized by excessive worry about daily life most days. So patients are worried about school, work, household stuff, to-do lists, and the list goes on. So just daily life stuff. And with all of this stress, patients can be restless, experience muscle tension, they can be irritable, there can be disruptions in sleep or concentration, and even fatigue. Now, why would they be fatigued? Well, if you think of all this restlessness and muscle tension and disruptions in sleep, then you can imagine that by the end of the day, they're just exhausted. Or even at the beginning of the day, they can just be wiped out and fatigued. And to diagnose a patient with generalized anxiety disorder, they need to have 3 or more of those symptoms we just discussed for 6 months or longer. And this 6-month mark is very important because it helps distinguish stressful events that can raise someone's stress level for a short time versus an actual disorder that should be treated. And treatment involves bringing those day-to-day stress levels down. And first line for this is cognitive behavioral therapy, along with SSRIs and SNRIs. Recall from Section 2 when discussing CBT that patients are taught good coping mechanisms and correcting incorrect and maladaptive beliefs. So CBT can have a huge impact on decreasing anxiety as patients start to recognize and develop better stress management tactics. Now notice that the treatment for generalized anxiety disorder is very similar to panic disorder. Both treatments are aimed at bringing down stress levels and working to prevent anxiety. Now let's talk about second-line treatments. They're second line for a reason. Buspirone is typically less effective than the above listed treatments, so you don't want to go to this one first. Most people find it's not that helpful. Another second-line treatment is benzodiazepines. They're very effective at reducing anxiety, but it's a terrible day-to-day treatment. For example, benzodiazepines are basically like alcohol since they stimulate the same receptors as alcohol. So essentially, these benzodiazepines make the patient buzzed enough that their stress is diminished. But do you really want your patient with generalized anxiety disorder drinking alcohol every time they get anxious? They'd likely be drunk all the time. And that's a bad coping mechanism and doesn't really get to the problem and help them develop better strategies. So saying that these are not first line and are second line is actually giving them too much credit. Now let's discuss obsessive compulsive disorder. This disorder is characterized by intrusive thoughts, which we classify as obsessions, followed by repetitive actions, which are the compulsions. So for example, an obsession could be safety, and the compulsion associated with that obsession could be locking the front door 12 times. Or if a patient's obsession is sanitation, then they can be compelled to wash their hands over and over again, like 6 times. Now, it's very important to recognize that obsessive compulsive disorder is ego dystonic, and this means that their behavior is out of line with their ego, so it's ego dystonic. In fact, they're usually upset and want to fix their obsessive compulsive behavior. And this is an important distinction because obsessive compulsive disorder is often confused with OCPD, which is obsessive compulsive personality disorder. That disorder is ego syntonic, so the behavior in OCPD is in sync with that person's ego. So those patients are ego syntonic. And OCPD is covered in great detail in the personality disorders lecture. Another interesting fact is that obsessive compulsive disorder is associated with Tourette syndrome. Now there's one good example of obsessive compulsive disorder. It's kind of a subcategory, and it's called body dysmorphic disorder. What you need to know about this disorder is written here. In body dysmorphic disorder, the intrusive thoughts or the obsession is one's appearance. So they're fixated or obsessed with a cosmetic imperfection. And the compulsive behavior in response to that can be repetitive mirror checking or even surgeries. There's other things like excessive grooming or camouflaging, which is basically using clothing or makeup to hide what you perceive as a defective body part. So now let's talk about diagnosis. How do you know if your patient has obsessive compulsive disorder? Well, basically, if they have obsessions and compulsions and they're distressed by it. In other words, there's a recognition that their behavior is strange. So they're ego dystonic. The first line treatment for that is basically what we've discussed before. CBT, which is basically teaching and training and therapy, as well as pharmacological treatment, including SSRIs or SNRIs. Depending on what resource you're looking at, you might find that SNRIs are used as a second-line treatment, and one that's often mentioned by name is clomipramine. But ultimately, it's safe to assume that for these anxiety disorders, you can start with CBT and SSRIs or SNRIs. Now let's talk about phobias. These include agoraphobia, social anxiety disorder, and specific phobias. Agoraphobia is fear of extremely open or closed spaces, and that's because they feel like they will be unable to flee. The first disorder we discussed was panic disorder, and we said that the patient may experience behavior change as a result of that panic attack. One of those behavior changes could be developing agoraphobia. So why does this make sense? Well, agoraphobia is fear of extremely open or closed spaces because you can't flee. And a patient who fears having another panic attack may develop agoraphobia because they don't want to find themselves in a situation in which they can't flee. Because after all, panic attacks are very disabling. Remember, they feel like they're dying. To be diagnosed with agoraphobia, the symptoms must be going on for 6 or more months. And they need to have that specific fear of extremely open or extremely closed spaces, in at least 2 situations. And just for clarity, to have agoraphobia, one doesn't need to be afraid of having a panic attack. They just need to have any reason that they're afraid of open or closed spaces because they can't flee. There can be a lot of reasons for that fear. And when we talk of having at least 2 situations, these need to be 2 different circumstances that cause this patient to be afraid. For example, they need to have fear of walking through an open park. That would be one situation. And then they can have fear walking around a small market. So that's 2 situations. And the fact that there's this requirement for having this fear in 2 different situations is very logical. Let's use this example to explain why. Let's say a patient says, I hate going to the park and I just really hate that park. Then you start thinking, well, what's the deal with the park exactly? And if they have a phobia of the park, you might want to address a specific phobia of the park. Maybe there's something there. Maybe they have a phobia of homeless people that are at the park. In other words, if they're not experiencing this dramatic fear in at least 2 situations, then you should be thinking more of a specific phobia instead of agoraphobia. And when it comes to treatment, hopefully you've realized by now that treating anxiety disorders is pretty straightforward. Cognitive behavioral therapy is almost always the right answer, and SSRIs. Now let's dive into social anxiety disorder. The fundamental problem here is an extreme fear of social embarrassment, and this leads to a behavior change. And it's important to distinguish that while a person with social anxiety disorder may not attend an event due to extreme fear of embarrassment at the event, and distinguish that from an agoraphobic patient who may not attend the event because their fear of not being able to find help or escape the place. And with most psychiatric illnesses, it's best to think of the root cause. Social anxiety disorder patients have fear of social embarrassment, whereas agoraphobic patients are afraid to have an inability to flee. And again, the go-to treatment for most anxiety disorders is CBT and SSRIs. You can also provide treatment for a specific performance. For example, a patient can have beta blockers on hand so that when they go for a public speaking assignment, they take those before. And that can slow their heart rate down and just make them a little bit calmer. Now, benzodiazepines are also possible to give in advance of a performance because it will calm the patient down. But if the patient's going to go give a speech, it's probably best they're not buzzed like they're drunk. So again, benzodiazepines, use sparingly. Now let's discuss the last phobia, specific phobias, which is essentially a limitless list of things to be afraid of. But with any of these specific phobias, there's an exaggerated fear of one specific object or one specific situation. They can have an exaggerated fear of spiders or heights. And this irrational fear must persist for 6 or more months. And treatment includes CBT, which is used for basically any anxiety disorder. But it's with these specific phobias that we deviate a little bit from the previous first-line therapy. In place of that, there's exposure therapy. Let's describe what this is. The idea behind exposure therapy is to gradually increase the patient's exposure to the phobia. And this gradual increase will help the patient build confidence that the fear is irrational. For example, if the phobia is spiders, then you can start by talking about spiders. And then your next session with the patient, you can show them pictures of spiders. And on the next visit, you can bring a spider in a cage. Then on the next visit, you can open the cage. And on the next visit, the clinician can hold the spider in his or her hand. And then eventually, you can have the patient hold the spider. So you can see this gradual exposure, and the patient will build that confidence over time. The final disorder is trichotillomania. This is a compulsive pulling out of one's hair. And you can imagine with all this hair pulling that on examination, you can see areas of thin hair, and you can also see hair shafts of different lengths. And in extreme cases, you might see bald spots. And the timeline isn't really relevant here, because if somebody's just compulsively ripping out their hair, you've got the disease, regardless of how long you've been doing it. And the mainstay of treatment is CBT. And very similar to specific phobias, there's not a great role for pharmacotherapy in these patients. They're less useful. Now that we've covered everything in this table, let's do a quick question to apply what you've learned. A patient is afraid to go out in public because he often embarrasses himself whenever he has conversations. He has relied on his neighbor to do his grocery shopping. He hasn't been to a public space in over 15 years. Does this patient have agoraphobia or social anxiety disorder? Now, agoraphobia is associated with a fear of public spaces, and social anxiety disorder is as well. But remember that with agoraphobia, the root fear is feeling trapped or an inability to escape. Whereas with social anxiety disorder, the root fear is being worried about social ramifications such as embarrassment or humiliation. So what is our patient afraid of? He's afraid of embarrassment. So this patient has social anxiety disorder. And that concludes this section.